All right, so again, welcome everyone. Dr. Boyce here, good to have you, good to be with you. And we're going to talk today very briefly, I think, because there is so much to talk about with respect to HIV cure. I just want to give some of the greatest hits, shall we say, about HIV and HIV cure that has been coming out over the last couple of years. I think this is sort of the holy grail of HIV. That I think there was some conference we went to some years ago, and one of the presenters was saying HIV cure is always 5 years away because it's so close. You feel it. It's just one or two things to fix, and we've sorted out HIV cure. But it just seems that the more we learn about HIV, the more we realize that it's very wily, it's very tricky, and it's been frustrating some of the most brilliant scientists in the world for many years. So let me just start the presentation. Let's make sure one sees. Can I see? Oh dear. Give me just a second. Okay. The technology is not being kind to me. All right. Are we seeing? Yes? All right. So this is just an acknowledgement of the support we got forth from ITech and the University of Mexico in setting up our ECHO program. And I have no disclosures with respect to this particular presentation. So this might sound like a strange question, but it's a necessary question. And that is, do we really need an HIV cure? If we think about all the other chronic disease models, whether it's diabetes, hypertension, cardiovascular disease, why not just follow a chronic disease model when it comes to the management of HIV? Why are we chasing down cures so much? Because by any stretch of the imagination, a lot of the news that we've gotten with respect to HIV and its management has been pretty good ever since antiretroviral therapy became available. So there's been, across whatever age group you check, global death rates are down. That's the chart to the left. The chart to the right, what essentially this chart is showing is increasing life expectancy from the early heart era, that's 96 to 99, going forward to about 2008, 2010. So this is even older data. But what it shows is that beginning the early antiretroviral therapy era, going forward over the next few years, there's been an increase in life expectancy by at least 10 years. And this is for both men and women, the lower two curves. And the higher two curves, if you take away the first year follow-up, because in a lot of places around the world, the mortality is highest in the first year because persons with advanced immune deficiency or with serious opportunistic infections don't make it past their first year. So if you were to check, if we exclude that first year, the life expectancy is even better in the second and third years of follow-up, right, for both men and women. And in terms of our own data, from 1990 to now, this is based on the 2020 UNAIDS estimates, there's been a 76% reduction in new HIV diagnoses over the last 10 years. There's been a 27% reduction in AIDS-related mortality, and there's been a steady increase in ART coverage in that 10-year period. And this is data actually we got very recently that from when we were looking at how many cases we get a year. So it peaked at about 684 in 2003. And so far in 2021, when this chart was done just a few weeks ago, we're down to 154 cases for the year. Now we understand that COVID is playing into this a little bit, but generally speaking, we can see that there's been a steady downward trend over the last several years. And maybe you can see there's a slight plateauing in the last, this is 2017 to 2020, right? Now, all that good news being put in the belt, baked into the cake, what is the concern with respect to HIV long term? So this is a study that was done in the US that shows that the difference in overall life expectancy between someone living with HIV on antiretroviral therapy versus someone who's HIV negative, the difference in life expectancy decreased from about 22 years in 2003 to about 9 years in 2014, 2016. That was based on if that's when you start antiretroviral therapy. Because remember, as time has gone on, the medications are getting much better, and patients are doing better and better on treatment. And as a matter of fact, in persons who start antiretroviral therapy with CD4 counts greater than 500, that gap narrows to 6.8, which is even a smaller difference in life expectancy, HIV positive versus HIV negative. But and this is part of the reason why there is this constant push towards trying to find this cure. Persons with HIV, on average, experience comorbidities, and whether that is kidney disease, liver disease, lung disease, diabetes, cancer, or cardiovascular disease, on average, 15 years earlier than someone who's HIV negative. So even someone who's HIV positive on suppressive antiretroviral therapy, because we're beginning to understand more and more about the impact of chronic inflammation on the development of comorbidities over time, that and how these things manifest as these chronic comorbidities, we understand that this is going to have an impact further down the road. That the longer a person with HIV live, the greater the chances that they may develop one of these comorbidities, and that is going to have a serious impact on quality of life later on. So, and second, in terms of some of the challenges with HIV globally, so even though the picture we painted earlier was pretty good, there are still a lot of challenges. So as of 2020, there were still 37.7 million people living with HIV, and just under a third of them are not on treatment, which is a huge amount of persons who are not able to access treatment and care, and who are therefore vulnerable to all the serious adverse effects associated with advancing HIV disease. There were 1.5 million new infections over the course of last year, and almost 700,000 deaths. So we can't pretend that even in today's environment, with all the modern advancements in HIV therapy, because of things like stigma and access problems, and we can't also neglect the impact COVID-19 has had, especially this year, on access to medication, testing, treatment. We still have to understand that there are still persons who will not have the getting benefit of antiretroviral therapy. And additionally, the estimated cost of the resources needed to get us to those 95 targets is somewhere around 29 billion US a year. And I think a lot of us who are active in HIV treatment and care, I think are sort of finishing up sort of annus horribilis in terms of how this year went with drug stockouts and reagent stockouts and all these other things that COVID-19 had a direct role in, that we understand that we have to think about the longevity of the response and whether or not it is, this is something that we can continue in perpetuity. Right? So let's talk about what we mean when we talk about HIV cure. So we can think of HIV cure broadly into two categories. That there is what you call a functional cure, in which the amount of HIV that is present in someone's body is markedly reduced to the point where there is not a great risk of significant viral rebound. There is not a great risk of deterioration of health, even after cessation of what we consider now to be antiretroviral therapy. So that's called a functional cure HIV remission in some references. The other way we can think about HIV cure is, I think, the way most people think about it, what we call sterilizing cure or eradication of HIV, meaning every trace of HIV is totally wiped out from a person's body. I think that's where the initial efforts focus on, right? Because given what we know about HIV, and given the fact that, if you have a very small population of HIV latent somewhere, and we've seen this, of course, with antiretroviral therapy, people can be on therapy, undetectable for years and years and years. And when they stop treatment, on average, within 2 weeks, they rebound, right? So that the push has been towards sterilizing cure. But one of the things that experts in the field realize, for example, simian immunodeficiency virus, which is the monkey form of immunodeficiency virus, in certain, quite a few of monkeys infected with the virus, the virus is there, but a lot of times it doesn't get them unwell. Why? Because they've adapted to the presence of the virus over many, many thousands of years of evolution, so that the virus no longer causes the same sort of immunocompromise and damage and chronic inflammation and immune activation and all these other things that happens in humans. So if we can turn the viral infection from a progressive, unrelenting, fatal infection to a chronic viral infection and doesn't get anyone unwell, that's also a good outcome, especially if that happens off of antiretroviral therapy or any treatment whatsoever. So let's talk about what the major barrier to HIV cure would be, and that is something called HIV latency, right? So when we think about an immune cell, so CD4 cell being infected with HIV, we would have rehearsed all these steps really, and many times. So the HIV virus attaches to the CD4 cell, we use the co-receptors CCR5 or CXCR4. It gets on the inside of the cell, it releases genetic material that is carried to the nucleus, incorporated into the cell's DNA. The cell then starts to produce viral proteins that get assembled and released, and the cell dies either from direct effect of the virus causing the cell to die or from the post-immune system destroying that infected cell. But there's also another way that the virus can be present in those affected immune cells. So, and it's thought to happen in two different pathways. Either an active CD4 cell gets infected with the virus genetic material gets inside of the cell, but that cell then enters in an inactive state, right? So that the genetic material is in that cell, in a sense, it's sort of trapped in the genetic material of the cell. The cell is not active, it's not replicating, it's not active, so no transcription is happening, but that cell has virus on the inside. And if that cell ever activates or becomes transcriptionally active, then that cell can potentially release virus, right? Now, so the definition of HIV latency, therefore, is a cell that contains integrated HIV DNA, but is what we call transcriptionally silent, meaning it's not producing any genetic material, any protein material from the translation of genetic material. So these cells, and they can be both in blood or in lymph nodes or in lots of different anatomic sites all over the human body, form what we call the reservoir that people would have referenced before. And it is from this reservoir of latently infected cells that viral rebound happens after someone stops antiretroviral therapy. Because remember, the antiretroviral treatment would not be able to target those latent cells because nothing's happening inside them. The genetic material is there, but it's not active, so the medication doesn't do anything to it. And viral rebound, meaning that this reappearance of HIV virus into the circulation takes place but with very few exceptions, and we'll come to that in a little bit, in practically everyone living with HIV. Doesn't matter if you started treatment last month or 10 years ago or 20 years ago, and there's been some more recent research suggesting that doesn't matter what drugs you are on, even some of the newer, more potent agents, you still rebound in around about the same 2 weeks. So in terms of curing HIV, so it's not necessarily directly HIV cure, but it does have some impact on how we think about sequencing different techniques and different technologies in terms of trying to achieve cure in the end. So one of the ways we can think about setting the stage for later cure is having as small a reservoir as possible, right? So that the fewer of these cells that are latently infected, the easier, potentially, at least theoretically, it would be to clear that reservoir, or the lesser impact that reservoir would have in terms of latency and rebound after discontinuation of antiretroviral therapy. So one of the potential suggestions, and actually it has been suggested that, for example, the American guidelines say this, that early initiation of ART, so, and when we say early, we mean, for example, someone who's in acute HIV, they would have been infected and they were in circumcision, having circumcision syndrome, and they present to an alert clinician who realizes this person is recently infected, we should start them on treatment right away. Why? Because the thinking is that the sooner you start treatment is, the less potential seeding there is of virus into these reservoirs. And there's been, I just cited 2 instances where at least literature suggested this may have taken place. So the first one was a cohort of persons called the Visconti cohort. This is in France, and it was first reported in 2013. And they were following up 14 patients who had long-term control of antiretroviral therapy. And they were found to have low reservoir levels. There are techniques you can use to actually estimate the size of the HIV reservoir, how many cells are latently infected. Despite the fact that these 14 individuals would have discontinued treatment somewhere between 4.5 years on the low end and 12.5 years on the high end, so we didn't follow for that length of time, right? Between 4.5 years and 12.5 years after stopping treatment completely. The one common thing about all the patients in this group was that they had all started treatment within about 10 weeks of what we call primary HIV infection, right? So very early on in the course of the HIV disease. The exact reasons for this would not be, I don't think we couldn't figure it out. They believe it may have some genetic factors. They thought there may be differences in how their T cells would have responded to HIV infection. So, and the other thing that we need to understand is that this is very rare. It's a very rare phenomenon, what we call secondary viral control. As a matter of fact, we had such a patient some years ago. He had stopped antiretroviral therapy for 6 months and came back to us with an undetectable viral load, right? So it happens infrequently, but it's not the same thing as a functional cure. And we'll get to that with the next case, which is what some of us remember called the Mississippi baby, which was also reported in 2013. And the story was the child was born in 2010 to a mother who had no antenatal care, who I believe had substance use disorder. And when she was tested when she presented in labor, she was found to be HIV positive. So a very alert pediatrician decided to start the baby on antiretroviral therapy within 30 hours of birth, right? And the child was tested subsequently and was found to have virus in plasma, so the child was in fact HIV infected. And received 18 months of treatment, but at 18 months, mother fell out of care. So, and stopped antiretroviral therapy. And when eventually she came back into care, before the pediatrician started back on HIV therapy, they actually checked the child's viral load and realized the child had no detectable trace of HIV anyway, right? Extremely low levels in proviral DNA, which is DNA, HIV DNA incorporated into CD4 cells. So the child actually remained virally suppressed for 27 months after stopping antiretroviral therapy. And at the time they thought, well, could this be a cure? Could it be proof that if you start treatment very early on in the course of HIV disease, that you could actually completely protect the patient from seeding of HIV into reservoirs, but eventually the child did in fact rebound. But it did give at least some suggestion of that this might be good practice with respect to reducing the amount of HIV and besides the HIV reservoir. So given what we spoke about in terms of HIV latency, then it might be reasonable to postulate that if there were a way to reverse this latency process, whereby essentially we kick the virus out of these latently infected cells, that this might be able to affect cure, right? So this is now one of the ways that is being actively researched now in terms of what we call latency reversal or shock and kill, meaning you activate these dormant cells, get them producing HIV virus, and in the context of one who's on suppressive antiretroviral therapy, of course. So as you thereby allow either the immune system to identify a target and kill these cells, or other things we're going to talk about maybe a little later in terms of how we then eradicate those activated cells from the person's body. Now, there are two broad types of latency reversal agents. The first is what we call a transcription activating latency reversal agent, meaning that it actually triggers or activates the genetic material within the cell, causing production of genetic material, release of HIV variants, and therefore either the cell either dies through direct effect of the virus itself or from immune attack, or immunomodulatory latency reversal agents, whereby the cell itself is activated. And by activating the cell, they then indirectly cause the cell to become transcriptionally active in terms of HIV proviral DNA. And then again, through the same mechanism, either through immune attack or through direct effect of the virus itself, that cell dies, right? And there are a lot of different types. I mean, even something like disulfiram, which we know about, that's used as anti-abuse for alcohol abuse. Mrftt also has been used. Some of the more popular ones that we know more about are the histone deacetylase inhibitors like vorinostat and those sort of things that would have been studied over many years. And also there are certain like cytokines like interleukin 15 and some of the immune checkpoint blockers we're going to come to. So there's an increasing pool of agents that are under investigation to effect latency reversal and potentially address the HIV reservoir. Now, the disappointment has been that when studies are done in terms of how well these agents work, they have found that they do in fact increase transcription. So you would find increases either in what's called cell-associated HIV or even sometimes plasma HIV on exposure to these agents. But with many of them, and I'll come to one exception soon, it has not been found to actually reduce the size of the reservoir, right? So that yes, you're triggering these cells to produce HIV, yes, you're seeing some effect, you are getting stimulation and activation, but yet the reservoir stays the same size. And so in which case you're not reducing the size, not shrinking it, not destroying it, you're just essentially getting it into motion. So there are studies ongoing pairing these latency reversal agents with other agents like immune enhancing agents, we might get to some, or pro-apoptotic agents, meaning, remember the way we said these latently infected cells die after activation, either through direct effect of the virus or through the effect of the immune system on destroying and attacking these cells. So if we pair the LRAs with agents that either promote the immune response or promote the death of infected cells, then we may have a shot at actually shrinking the size of the reservoir. And one of the issues that has been coming up with some of these agents is that in order to be effective, there's a limitation based on toxicity. So there's a real need to get more agents to be more effective that can be paired with other agents and are also less toxic. And also you can think about, thankfully, because of nanoparticle technology, there are lots of different drug delivery mechanisms we can think about in the future. So one of the very interesting mechanisms that actually came out very recently, I think it was in a study in 2021, was that immune checkpoint blockade is emerging as a potential tool in HIV latency reversal. Now, what are the immune checkpoints? So an immune checkpoint is a down-regulatory receptor, meaning that it damps, like it breaks on the immune system, that are expressed on exhausted T cells, both in cancer and HIV. And these immune checkpoint blockades has been found to be effective in difficult to treat cancers, actually, like melanoma, like refractory metastatic non-small cell lung cancer, which is a difficult cancer to treat. And these two immune checkpoint blockades, which is a PD-1 and CTLA-4, the acronym which I can never remember, right? But those antibodies directed against those immune checkpoints has been actually found to actually reduce reservoir size. And that is actually very exciting because it might offer another tool by two drugs that are already in clinical practice in potentially getting closer to HIV cure. The drawback with these drugs is that there is a potential for a serious inflammatory adverse effects. Remember what you're doing, you're essentially taking the brakes off the immune system and letting it run free, right, without a check and balance, because that's how our immune systems work. That in response to an antigen, there's immune activation, and then these checkpoints tamp down the effect, the activation of the immune system after a certain period of time or response system trigger. Removing those triggers runs the risk of an out of control immune system, potentially even autoimmunity. So there's a balance that needs to be struck, because if you're treating someone for a fatal illness like metastatic cancer, there's a much different risk-benefit calculation as opposed to someone who's stable on treatment, in no danger of having a fatal outcome, and exposing them to a drug that has a significant risk for an adverse outcome. So any conversation about the cure of HIV must include the only two cases that we know of that have been directly cured as the result of an intervention. Right? Separate and apart from persons who might have been, for example, the persons, the Visconti cohort, persons who are off treatment and they have undetectable viral loads. That wasn't done that didn't happen as a result of a specific intervention. This kind of happened when trying to figure out how it happened. In these two cases, these so-called Berlin patients, Timothy Ray Brown was cured in 2007 and sadly passed away last year, I believe. And Adam Castillejo, who was the London patient, quote unquote, who was cured 10 years later. And essentially, the London patient followed the example of the Berlin patient. They were both being treated for hematologic malignancy. One was leukemia, one was lymphoma. They both required bone marrow transplantation. They both had stem cells that were from a compatible donor who happened to have a genetic mutation that by which they were missing a certain co-receptor for HIV on their T cells called CCR5. So this particular stem cell transplant was missing this receptor. So it rendered any T cell that was generated from that transplant resistant to HIV infection, right? Because essentially the virus doesn't have anything to lock on to. So both in the case of the Berlin patient and the London patient, they also both had graft versus host disease, meaning that the remainder of the patient's immune system actually attacked the graft, and there is some suggestion that that fact might have actually furthered the clearance of the reservoir, because essentially what you get is inflammation and injury to the graft, and that might have actually caused a further eradication of any residual HIV-infected cells in the original patient. So the question is, can we modify host T cells to essentially mimic these CCR5 deficient cells? And there is, again, a lot of work trying to see how best this could be done. Now, it is not an easy conversation, because remember anatomically where the reservoir is. Some of these latently infected cells are in plasma. So one can consider removing CD4, the T cells from the person's body, exposing them to this technique, whether it's, so there are different ways it can be done, either zinc finger nucleases, CRISPR-Cas9, or something called TALENs. Again, the acronyms I can never remember. But essentially what they do, they would actually, they can be used to target specific sequences of DNA and modify them. And then the natural DNA repair mechanism would essentially just heal the area where the DNA was modified, right? So you can divide the gene for the CCR5 gene, you can excise it completely. Now, sorry, CCR5 or CXCR4, because remember both of those genes are co-receptors in
HIV entry into cells, more CCR5 than CXCR4. Right? So if you were to be able to modify enough of these cells and then transfuse them back into the person's blood, then those transfused cells would be resistant to HIV infection. The question is, what would be the long-term outcome of that? And how many treatments do you need? Because short of going through the process that the Berlin patient, London patient went through, which is expensive and which has a mortality rate that can be as high as 25%, it's not something that's scalable. It's not something that's accessible in most places. Given where we know the distribution of HIV is around the world, even though these are interesting and potentially very exciting, are they scalable? Are they, for example, if you think about, in a rural village somewhere in the African subcontinent, how are we going to access gene therapy if we can't even manage a cold chain? Right? Now, one of the other mechanisms that can be used is not so much targeting the receptors to HIV, but targeting and enhancing T cells to make the T cell receptors more active and have more affinity for certain HIV epitopes. Because one of the major ways by which our immune system protects us from HIV is what we call a cytotoxic T cell activity. In other words, the cellular response killing infected HIV cells and also removing any free virus from circulation and that sort of thing. But because of the fact that HIV does mutate so often, and because there's so many different quasi-species, that the immune system is always playing catch-up. So if you can program T cells to attack, for want of a better word, stable epitopes or stable antigens in the HIV envelope, it would make the response more specific, more durable, and less likely for HIV tests to escape. And one of the final ways that I'm just going to mention today in terms of gene therapy, one of the other areas that is under active investigation is using, again, CRISPR and sometimes zinc finger as well, to remove the portion of the HIV DNA that is incorporated into the host genome directly, right? And allowing the normal DNA repair mechanisms to heal, to fix the DNA break after the viral DNA has been removed. So it has a potential to eradicate, all latently infected cells. I mean, you can deliver the CRISPR through a viral vector, for example, and that can get into essentially potentially even areas that are outside the bloodstream. But one of the concerns that is raised about the applicability of CRISPR in this setting would be the potential for having areas of injury to the human genome in places you didn't expect it to or don't want it to. There has been some evidence, for example, that you're aiming for portion A, but remember, given how complex our DNA is, if let's say you're targeting a certain sequence, if that sequence happens anywhere else and in a place that might be sensitive, for example, at an oncogene, at a place where if you ping the DNA at this point, you might run the risk of switching on a cancer gene. So it's one of the things that, again, is going to require lots of further study. And it's potentially very exciting, but we need to make sure that we balance, the risks and the benefits in terms of affecting HIV cure. So I think I'm going to summarize there. So in terms of HIV cures, the major barrier to cure remains this latent reservoir. It's been bedeviling best of scientists in the late 90s when we understood this issue about latently infected cells. There are multiple approaches under investigation, either to destroy or to inactivate latently infected cells, and this is not a comprehensive list. The things I brought
protein neutralizing antibodies, there's immunotherapy, there's therapeutic vaccines, there's so many other things. But for global HIV cure to be a thing, those strategies must be scalable. In other words, you have to be able to think how getting to 37 million people. It must be affordable. It must be accessible and acceptable if any of these cure strategies are to have any impact on the global HIV epidemic. And that is my final slide, so I'll end there. And I will open the floor for any questions or any comments at this point. Thank you very much for your attention.
Thanks so much, Dr. Boyce. I want to ask a question in terms of some of the things we hear sometimes on like the internet, on Instagram and these places. Does it mean therefore that when they speak about testing moving to humans and things of that nature, this is merely an attempt to make it more affordable and accessible? And so does it therefore mean it's still very far off as far as the idea of any cure taking place?
So when you say testing, you mean for these sorts of cure strategies or?
Yes.
Right, so I don't think any of these things I highlighted is as of yet at the point where you can think about having large trials. They're more or less proof of concept. There's been evidence. We're going through the whole, animal testing, safety testing in humans. So what they're trying to do is actually find out whether or not there is any effectiveness. Is there any point moving forward? For example, when we talk about reducing the size of the reservoir or reducing the speed at which viral rebound occurs, that's kind of where the human testing is, right? So far, at least with most of these things, it would proven to be safe in humans. But what we're trying to figure out is it effective? Does it actually do anything, right? So, for example, we spoke about the latency reversal agents. That yes, they do in fact promote replication and activation of the cells and reversal of latency. But if it's not reducing the size of the reservoir, then we're not accomplishing anything. Right? So it's small steps right now. Right? I think we've made a lot of the big steps already, in the sense that we can more or less guarantee anyone living with HIV, once they diagnose early, will not die from HIV. I mean, that's an ironclad guarantee at this point. Yeah. So I think the question there with these cure strategies is, can we find a strategy that can eradicate HIV? Because you have to come better than, I'm never going to be sick a day in my life. You understand where I'm coming from? Because currently available medication, you already guaranteed that. So if you're talking about HIV cure, it has to be as good an outcome, right? As never sick a day in my life with one tablet a day or one injection a month.
I see we have a comment in the chat box. I remember reading recently about the HIV vaccine in a BBC article. Would you say because of the nature of the pandemic in today's world, focus on an HIV cure has shifted to prevention via vaccination as opposed to a sterilized cure?
So I think there has always been an emphasis on vaccination, because if you, and this is very apropos with what we're going through right now, COVID vaccination. So I'm going to show my age. If those of you remember, how I pick a pan, right? Well, today we're going to talk about pick a pandemic, right? So whether it's smallpox, polio, measles, anything, we go all the way back. We vaccinated our way out of those things, right? HIV, because I think when HIV hit, we were actually in a position in terms of biotechnology and all the processes that we could actually find treatment, suppressive treatment, in a relatively short period of time. But it has been very difficult so far. I don't think there's ever been a successful vaccine. No, I don't think there has never been a successful vaccine candidate, because of how slippery HIV has been in terms of the mutations and immune escape and all those sorts of things. They are trying, and they have been trying to target some of the conserved areas so that the vaccine potentially might have more activity against the various quasi-species, but so far it's all been a little bit disappointing. There was a recent vaccine candidate that was very, very promising, but it just wasn't protective enough. So I don't think that necessarily the emphasis is shifting away. I think people are still, and researchers are still hoping to get at a vaccine because, again, that's how we got out of all the other pandemics, but HIV is proving to be extremely difficult.
Maybe just to add on that point for the sake of Conrad, people are still working hard on HIV vaccine. And I think right now there is a collaborative effort of a vaccine trial between the Americans, South Africa, and Kenya. But as it has been happening every 5 years, there's always the promise that people are working on a vaccine and it seems to be successful or has a promise. And then they drop the bombshell that the vaccine failed. But people, they have not stopped, they're still trying. Dr. Boyce asked at the beginning, why are we talking about HIV cure? And what was ran through my mind is the fact that we still know and that HIV is an infection. And to the general public, most, if not most of the infections are curable. And patients still ask every few days, will there be a cure for HIV? Will there be a cure for HIV? And leaning towards what Dr. Boyce has presented today reminds me of some meetings some years ago, almost 9 years ago, when I found myself with some researchers from France and England and some other parts of the world. And one guy's comment was that HIV cure one day might come about, but it requires collaborative efforts amongst many different cadres of science. One particular group of scientists are not going to get a cure at all, but with collaborative efforts of immunologists, physicians, physicists, even engineers and biochemists and so on, geneticists, then one day people might come up with something that would work. The surprising thing is the fact that there are these few isolated cases where people want treatment, like the Vincenti group and the famous, not very famous, but the French girl who was a mother-to-child transmission case was on treatment. But in the year 2015, she had maintained undetectable viral load for about 12 years without any treatment. And I just saw an article about a Buenos Aires lady who was diagnosed in 1996, was on many, many different regimes of ARVs. In 2007, she stopped taking all of them because of side effects. And up to last year, she has maintained undetectable viral loads. And the most interesting thing about this particular case is that she doesn't even have antibodies against HIV anymore. So something will come one day. As to when, it's difficult to say. Because a few years ago, there was this promise also from Israel. I don't remember what they were trying. And it was like Israelis were working on something which would be very useful in probably curing HIV. Again, I haven't heard anything about it anymore. But all this is work in progress. And even the people of stem cell who have had stem cell transplants, I think they've had a few people in Boston, they've had a few people in Australia, some people in France, and I think all of them failed miserably. So whatever it is about cancer patients going through radiotherapy, chemotherapy, stem cell transplant, and then it seems to be successful. But there's a very expensive modality of therapy that I don't think you're going to subject somebody who doesn't have any malignancy to radiotherapy and chemotherapy, and then you give them stem cell transplant and hope that will be cured or potentially cured, apart from the cost, which is also exorbitant.
And you have the anti-rejection medication Yes. So go from taking one tablet a day with no side effects to a whole set of tablets, and you might get die from something more side effects. Cured, but the cure might worsen. It makes no sense at all. So, question from Kizio: what gene therapy approach is used to remove CCR5 from CD4 cells? So that's still investigational, right? It's not anything that any patient will get access to. But the theory behind it is that you use either CRISPR-Cas9 or the zinc finger endonuclease to target the CCR5 gene, remove it, right, from cells that you would have harvested from the patient. And then you reintroduce those CCR5 deficient C cells back into the person, right? So in other words, the virus has fewer active targets even after rebound. Let's say if you were to stop treatment and the virus gets reactivated, it's now hunting for the CCR5 cells to find, it wouldn't be able to do that. The question is, how sustainable is that? Because those cells are not, immortal, right? And you are still having other cells being produced from your hematopoietic lineages, so that unless you do that over and over and over, and if you have to do that over and over and over, it's not a cure. Right? It's not something you have to do every day, but it's not a cure. But I think it's sort of trying to figure out, can you induce the same changes that occur in the bullying patient and the learning patient by artificial means? Okay. Sorry. All right. So let's see. Looks like we may have a short day today. We have no case today, which is just about right because just about 8 minutes left. Unfortunately, half our screen is in darkness. So
by the way,
I have to squint.
What's the position of the broadly neutralizing antibodies and other neutralizing antibodies in terms of cure? Because that's another thing that came with a ban, and then kind of just
so I think what happened with broad neutralizing antibodies is that, so there is evidence that these broad neutralizing antibodies can postpone the rebound sometimes by months, sometimes longer than that in certain persons. And there was a recent study where a certain, because they have different names, that sort of thing, was able to do it, but only in strains that were susceptible to that particular antibody, because remember, antibodies are very, very specific things.
Yeah.
So you're trying to have, even though it's broadly neutralizing, it's not universally neutralizing. So even if you're tackling 95% of all the virus that's there, that 5% is going to stick and it's going to escape the immune system and start multiplying over again. So what they're experimenting on now is multiple neutralizing antibodies, almost like immunotherapy. And it works in two different ways. So the first way is that these antibodies are active against a wide swathe of HIV. So any free virus in plasma gets an antibody sticks to it, your immune cells remove it from plasma. But the other thing it does is that by doing so, right, by these antibodies attaching to virus and removing them, remember the way pathogens are processed, you would then be sent to antigen-presenting cells, that would then present them to T cells, and then you actually produce immunity endogenously after infusion of the broadly neutralizing antibodies. So it's a sort of two-pronged method of broadening immunity to various strains of HIV. The problem would be how long does it last? Because so far this has not been permanent in enough persons for it to be used broadly. 1, 2, I'm sure it's just high motion, really expensive. 3, again, you require an infusion, however, in an academic center. It's not scalable. It's not easily accessible, but it's a good proof of concept because if we can train our own immune system to remove virus, that's a good thing. And the flip side of that would be remember one of the other problems with HIV is constant reactivation, right? So if we're not addressing that, then even though you know you don't have large amounts of virus in your plasma, if the cost of that is ongoing immune activation, well then we're kind of back to square one, because that will still lead to T cell exhaustion, we're going to have the immune system and potentially comorbidities long term.
Now, structured treatment interruption led to disasters in virtually all parts of the world. And yet from unstructured treatment interruption, people are able to suppress the virus being found. Is there a possibility that amongst the treatment cohorts all over the world, there might be more people who would be able to suppress the virus without continuing?
So no, I'm sure there are. But the problem is right now we don't know how to identify them precisely.
Yeah.
Right? So let's say we have Visconti cohorts, right? And when they compared what they call secondary controllers to elite controller natural viral suppressors, people who, even though they're infected, and we have a few in the clinic, virus have been infected for 20 years, right? But yet they are infected. What's different about that person? And they would have done lots of different tests, so you might find a certain HLA, B52, B27, you might have more of that, but not in everybody, right? They might have a difference in terms of the CD8 activity, but not in everybody. So it's likely not to be the same thing, even though the outcome is the same.
Yeah.
But what underpins that outcome is not likely to be the same in different people. So that makes it very difficult then to say, okay, I have 1,000 people. Let me take this blood test. Okay, you 3, 4, 5, you can substitute because you have this profile that means the virus will never rebound, right? But we just don't know. True.
I don't see any more comments in the chat box.
All right.
3 o'clock.
Close to 3 o'clock.
You've done well.
Let me see. So Conrad, do you have the because unfortunately I don't have it, but in the chat box. The Howard University clinical practice, community of practice. Unfortunately I don't have it. We'll send it out. I guess
Okay.
you.
Yeah, what we'll do is the Howard University is offering a number of different sessions, and so what we can do is we'll put that in the chat at the same time that we upload the video as well, so persons will have opportunity to see when those sessions are and be able to register for them also. Is that it?
Yeah, that's fine. That's fine. But just a plug, if it happens on the same day, please keep us company in preference to that. But once it's not the same day, the sessions are good, so I've attended them myself. So please take advantage of it.
And
right.
So our next ECHO session is going to be 2 Thursdays from now on the 25th of November, and it's going to be at the same time of 2 p.m.
All right. So everyone take care, be safe. I am going to eat something and drink some coffee.
Bye, everyone.
Everybody, be safe. Take care.